Hi guys, I'm Dr. Marwah, your medicine educator at PrepLadder. एक बार फिर से बोल दो तो मेरा फंबल था।
सॉरी कहाँ से रीटेक लें? स्टार्टिंग से कर दूँ या
हाँ फ्लो आ जाए।
ये एसी बंद किया है क्या?
हाँ कैमरा में देख रहा था, नहीं देख रहा था, वो तो कट आया ना बीच में। एक बार शुरू से ही कर लेते हैं, डिलीट कर दे यार। Today we are in front of you for an integrated session of medicine and pathology.
So without wasting any time, let us begin.
Hi guys, I'm Dr. Marwah, your medicine educator at PrepLadder.
Hi everyone, I'm Dr. Preeti Sharma, your pathology and microbiology educator at PrepLadder.
And today we are in front of you for an integrated session of medicine and pathology where we'll be talking about an important topic of cardiomyopathies.
Right. So as Sir mentioned, an important topic for all of the upcoming exams, and I'm sure the students have been looking forward to this. So without wasting any time, let us begin. Before that, I want to give you an overview about all the things that we'll be talking about in this short session. And these are the different types of cardiomyopathies that you all have to study. The first one being a very important exam question, and that is what we'll begin with. It is DCM or dilated cardiomyopathy. So of course, we'll start with the basic introduction and etiopathogenesis. The introduction or the definition, I believe, is the easiest for the students to understand, because dilated word itself tells us that there is going to be dilation of all the four chambers. Now that is what you actually had to note most importantly over here, that the dilation that happens is going to be of all the four chambers. So if we draw this heart over here, we would believe that the heart is now going to become globular and flabby, and that is going to actually contribute a lot to the clinical side also. So that's the first point that you have to note. It is all four chambers. But the second point which students often tend to miss out in this dilated DCM is that there is also hypertrophy of the cardiac muscle fibers. Now whenever you hear the word hypertrophy, your mind automatically jumps to HOCM or hypertrophic cardiomyopathy, and that is where you actually have to sit and read the question carefully, because if you have a combination of dilation and hypertrophy, you should actually be thinking of DCM also. So talking about the risk factors and the etiopathogenesis, the first one of course happens to be our most famous and favorite answer. So what is the most common cause of DCM? And that is, I don't know, idiopathic, right? And sir would also believe and agree with me that students find this to be their favorite answer in all of the MCQs. But in case idiopathic is not there and we have to pinpoint a certain cause, then we have two things we have to look out for. One is genetic, and of course certain non-genetic factors. So let us start with the genetic point over here. The first one that you have is autosomal dominant. Autosomal dominant inheritance means that whenever there is a titin-1 gene mutation. For those who don't know, in biochem and in medicine, you study that titin-1 gene or TTN1 gene actually encodes for a protein called titin protein, which is the largest protein that we have in our body. So that can obviously, a mutation in that can result in DCM. The second one is going to be XLR. For that, of course, you have to think of a gene that is present on the X chromosome, and that is going to be the dystrophin gene. You of course read a lot of other things also with the dystrophin gene in medicine. This is one of them, that dystrophin gene mutations on chromosome X can result in DCM. There is a rare DCM which can also follow mitochondrial inheritance, and this usually tends to have a childhood onset. So these are all the different genetic aspects. But apart from that, you need to focus on what? Non-genetic, because these will be certain histories which will be given to you in the clinical questions. Alcohol being one of the most important and major contributing factors out here. So you need to watch out for alcohol history being given in the questions. Apart from that, anthracycline, cobalt, cocaine, catecholamine, and sir would agree, sir, catecholamine gets a lot of questions in DCM and otherwise in medicine.
Absolutely. We will subsequently be discussing a question on the topic of broken heart syndrome, that is Takotsubo cardiomyopathy. An alternative term is apical ballooning syndrome. So I'll be giving a couple of bites about it in the later part of this video.
Great. So that is for the later part. But coming here back onto the other risk factors, we have peripartum also, which I want the INI-CET aspirants to especially note. Peripartum, of course, refers to somewhere close to the third trimester. So this usually presents somewhere around 30 years in a female and in the third trimester. So of course, a question coming to your mind would be a big why, with a lot of hypotheses behind this thing. One very commonly accepted is that this has been associated with the increase in the prolactin levels. So having discussed discussed all of these risk factors, we are actually ready to look at it from the pathology point of view before going on to the clinical aspect. So of course, starting with alcohol being a very, very important factor out here. You can see the heart over here and how it's globular and flabby. You can see all the chambers have been dilated. So dilation definitely happens to be the mainstay. But what I also told you, apart from dilation, was hypertrophy. So hypertrophy from your general path, is increase in the size of the cardiac muscle fibers. So you can see the cardiac fibers have become bigger in size. And if I actually want to zoom into these cardiac fibers and look at their nucleus, there's a very, very interesting finding that you find. And this is another good news for all of you, because there are not many images of ninja star nucleus available, whether it is in medicine or path or Google it out. This is probably one of the only rare pictures that you have. So if you're getting it in the exam, then this is probably it. So yeah, coming back, this is how a ninja star nucleus looks like. Just like if you are fond of the comics, you must have seen it there. So this is ninja star, and when you see this, of course you think of DCM, but any particular type of DCM, the one that is associated with titin 1 mutation, but not always, because ninja star nucleus happens to be a non-specific finding. So overall, if I want to summarize things for you, it's dilation, number one. Second, it's going to be hypertrophy. And third is going to be the ninja star nucleus. So that happens to be the end to the pathology discussion, but a lot more coming your way with medicine, of course.
Now, you guys would notice nowadays that the questions that come would be having a combination of a couple of options from pathology and some would be coming from general medicine. So this is one such example. And because they have made these time slots where you have to solve the question in a limited time frame, so I would like you to quickly go through the 4 options in this question and try and work out an answer in your mind while I give you an explanation. You see, dilated cardiomyopathy, whenever we read about it, as ma'am said, this would be an enlarged globular heart. So one very characteristic feature I just want to bring to your notice is that there would be a dilatation of the tricuspid and the mitral annulus. And because of this dilatation, there would be leakage of blood from the left ventricle to the left atria. And that's going to result in development of a very characteristic finding that I'm going to say, I'm going to say functional tricuspid regurgitation, functional mitral regurgitation would be occurring in this condition. And because of this, when we are going to auscultate these patients, we are going to have a murmur that would be called as a pan-systolic murmur. And I think before I mark the answer to the question, let me give justification for the other options as well. In this condition, we get a very peculiar finding that the pulse is felt by you both in the phase of systole and diastole. You see, normally the pulse is felt by you only in the phase of systole, but you get a dicrotic pulse in this condition. In fact, a mnemonic that I can quickly mention here at this moment is the ABCD of pulse, where alphabet A is pulsus alternans that we get in left ventricle failure, pulsus bispherians in hypertrophic cardiomyopathy. I'll talk about it in the later part. Then we have a collapsing pulse of aortic regurgitation, and then D would be dicrotic pulse, the peculiarity of this particular condition. Well, as far as hypertrophy of myocytes are concerned, I can say, as ma'am said, this would be more of an compensatory mechanism because the remaining myocytes have been damaged due to toxins like alcohol. And when I talk about alcohol, what always comes to your mind is always holiday heart syndrome as well, where we get an atrial fibrillation, which can cause a sudden cardiac death. Now, because we know that these patients can suffer from sudden cardiac death, so we usually deploy a device that's called as a implantable cardioverter defibrillator. INI-CET is going to be different from a pacemaker because pacemaker is for bradyarrhythmias. But in those conditions where we have tendency for tachyarrhythmias, we deploy ICD. This would deliver a DC shock. This small tiny device has sufficient punch and power to deliver a DC shock even without the patient coming to be aware of it. And well, this guy is maybe partying, maybe boozing. He developed a tachyarrhythmia, but the computer is going to shut off the tachyarrhythmia right in the beginning, so you would not have a hemodynamic compromise. So that tells us that option number A, C, D are very well justified. But then if you look at option number B, mid-diastolic murmur is what you read usually with Caricum's murmur, or I can say Austin inflamed or mitral stenosis. I mean, I'll not get into a mnemonic at this moment, but yes, MDM is very characteristic for at least one term that you can remember at this moment is mitral stenosis and Caricum's, because both of them are going to be related to each other. So that would be my bites with respect to dilated cardiomyopathy at this particular point of time.
So having discussed dilated cardiomyopathy from medicine and pathology, let us now move on to HCM or HOCM, that is hypertrophic cardiomyopathy. The inheritance of this also happens to be autosomal dominant. So watch out in the question that there will be a history where either the father or the mother or someone in the family would have something similar mentioned. And the defect. Now I can go on and so can Sir, because the number of mutations in hypertrophic cardiomyopathy are innumerable, but we would want to limit it to what is important for you. So beta myosin heavy chain or MHC, and there's a very easy way of learning it, that when you go for HCM, which is hypertrophic cardiomyopathy, if you rearrange the alphabets, you get the name of the gene also. That is one of the common ones that have been found over here. So I think I can directly explain with the help of this diagram or autopsy of the heart, which shows you that the name suggests us that hypertrophic is going to show you hypertrophy, and this is very characteristically defined as the asymmetric hypertrophy. So what do we mean by that? Many of us know that there is hypertrophy of the interventricular septum, which is there. But apart from that, the hypertrophy of the free wall of the left ventricle cannot be ignored. So there is hypertrophy of both. But when I say asymmetric hypertrophy, the hypertrophy of the interventricular septum is probably more in comparison to the free wall of the left ventricle. So I'm not good with making heart diagrams as much as Sir is, so my heart diagrams are usually these window hearts. But over here, if I have to mark out, the interventricular septal hypertrophy happens, and of course, there is hypertrophy of the free wall of the left ventricle. So you can very well see what has happened to the lumen of the left ventricle. And that's the famous banana-shaped heart. And if I have to mark it out in this autopsy picture, I can very well see that this is the banana-shaped heart that all of us can visualize over here. So of course, this is going to result in an obstruction to the outflow of the heart, which we will study in a while. But before that, if I just have to cover the entire pathology and show you how exactly is it going to look under the microscope. So this is that typical pink and blue of pathology where you expect that cardiac fibers should go in one line, and they are not. Over here, all the cardiac fibers are going in a random fashion. Either they can go diagonal or horizontal or vertical. That's another picture that has been given to you over here. So rather than calling it haphazard, what they like to call it is the helter-skelter appearance. Helter-skelter appearance of cardiac muscle fibers. You have to watch out for this. Why? Because right now, both of us just taught you that hypertrophy can happen, of course, in DCM also and in hypertrophic cardiomyopathy as well. But this helter-skelter appearance will only and only be seen in HCM. So, of course, this has a very, very important clinical aspect related to sudden death, which I believe Sir is the best person to explain that to you.
Since the objective of this video is a spaced repetition, so you will be finding some terms that would be repeated. And again, I'm putting a question here before you, which would say which of the following is not correct. So a lot of these questions would either be having an except or a not present. So let's handle the options here. The first one says a systolic murmur. You see, hypertrophic cardiomyopathy, as ma'am pointed out, is a condition where there's a hypertrophy of the interventricular septum. The obstruction is not at the level of the aortic valve, but the obstruction is that hypertrophied muscle in the heart itself will act as an impediment to the exit of blood. So the technical word that I want to put your attention to with respect to this particular condition is a dynamic. That is when the heart is contracting, that is when the free wall and the interventricular septum that is hypertrophied would come closer to each other, and the heart is literally squeezing its own output. So the technical term that we read for this is always LVOTO. That's a left ventricular outflow tract obstruction. Why we're saying dynamic here is because during the phase of contraction, there's going to be squeezing or there's going to be a limitation of the exit of blood out of the heart, and therefore there would be a decrease in the ejection velocity of the blood while the blood is going out. In fact, one of the characteristic pulse that would be seen in this condition would be technically a twice beating pulse, but this time the twice beating pulse will be in the phase of systole. And if you're paying attention, earlier I was saying the word twice beating pulse with respect to systole and diastole, that's a dicrotic pulse, but in this case you can see two peaks. The first peak is due to the pressure that was generated by the left ventricle, and then I have shown a drop in the ejection velocity. That drop is primarily because of this dynamic left ventricular outflow tract obstruction where the heart itself is suffocating its own cardiac output. So as far as this condition is concerned, yes, it contributes to development of sudden cardiac death because the demand of the heart is more. You see, in chronic stable angina, we always talk about a supply problem. If somebody is having an atherosclerotic plaque in the heart, it would decrease the cardiac output. If you have decrease in the blood supply of the coronary arteries, I mean, there would be a ischemia component present. But in this condition, I'm not saying that there is any problem with the coronary blood flow. It's rather the demand of the heart which is dramatically increased, which explains two things. The initial symptoms in these patients would be one, shortness of breath, and second can be chest pain. And a lots of time these patients might actually neglect their findings, and especially when when they're doing any kind of special activity. This could be as simple as dancing at a marriage party. I'm not talking about somebody who's going to be an athlete at an international level. People with HCM, please be very, very clear. They would never be able to perform at forget about an international level, forget about even a state level, even at a school or a college level football, where like you and me would have played in our school. These patients would not be able to do it simply because their left ventricle has a smaller cavity. So this is primarily an example of a diastolic malfunction. And why do you have sudden death? Usually when you read that question, sudden death in a footballer, the impression is that's a professional footballer. No, guys, it's not. It's just a guy who's a rookie, a simple guy who just tried to play around with his friends, knocking the ball around with his friends, and he will collapse. Why does he collapse? Because there's going to be ischemia component that will contribute to development of primarily ventricular fibrillation. So that's the correct option in this condition. And then, as I explained, pulses variance in this condition. And because the word is hypertrophic, so this condition also has increased ejection fraction. Among all the cardiomyopathies that we're going to read, it's always going to be a low ejection fraction. But this has a peculiarity. We are having a high ejection fraction. On this, the query of most people is, sir, if it's going to be an increased ejection fraction, what's the problem? Well, man, that's the entire game. You see, if you look at the term ejection fraction, then this is only a mathematical ratio. It is stroke volume divided by end diastolic volume, and therefore what I can say is, if mathematically if I decrease this value denominator, then the ratio will obviously increase. This is a pure diastolic malfunction in the heart, because as ma'am said, banana shaped cavity, for me it would be decrease size of the cavity of the left ventricle. It would receive less blood, input is less, output would also be less. So ejection fraction increased is, I would say, this is pure mathematics at play. It has nothing to do with the actual hemodynamics of a patient. Less blood comes in, less goes out in these patients, and because it's an outflow tract obstruction, you get a systolic murmur as well. So that leaves you with one option by exclusion, and that is what I want you to practice. Exclusion skills for MCQs: increased LV diastolic dimension. I mean, just read that statement, right? When I said that this is going to be a banana shaped cavity of the heart, when I said there is going to be a smaller left ventricle of this patient, remember the heart is bigger. The heart is bigger, but the cavity size is smaller. So that makes answer to this question as option number D. And well, these are the clinical bites that you need to know. Plus, I would like to emphasize once again why they die suddenly. Your answer would either be ventricular fibrillation or PVT. That's a pulseless ventricular tachycardia.
So moving on to the next cardiomyopathy that we have, that is known as ARVCM, arrhythmogenic right ventricular cardiomyopathy. As the name suggests, it's going to be primarily involving or a defect that is going to take place in the right ventricle. And as always, we start with the inheritance, which is going to be autosomal dominant. And there is going to be a defect in the desmosomes, especially something called as plakoglobin, which I will tell you in a while. But what exactly is happening in the right ventricle, you can visualize directly with the help of this diagram. If you look at this cross-section shown, the thicker wall, of course, everyone knows is going to be the left ventricle. And on the other hand, the right ventricle that is shown is looking thin, of course, but what I can actually see over here is that I'm visualizing something that has come out in the right ventricle, which is yellow. Now, when I say yellow, that means that there is actually fatty infiltration that is not expected that you would see that in the heart. And the same thing, if I want to visualize it under the light microscope, we all know that fat is going to be completely washed out because of all the chemicals that we use in pathology. Fat tends to get washed away and we see clear white spaces. So this is again fat which is present in the right ventricle, which is again going to tell me about ARVCM. So that is what you need to know for the desmosomal defect. But I just wanted to add on to that, because apart from this, that is a syndrome called the Naxos syndrome, where again the patient has the same ARVCM and fatty infiltration that I told you about. But apart from that, you can visualize over here that there is a child who's also going to have woolly hair. And if you look at the palms and the soles, so there is going to be a defect that is also going to be seen, that is palmar plantar, and that defect is that they are going to be thicker. Now, if you go into your basic dermatology, the thickness of the skin is always because of the topmost layer, that is keratin. So I can safely say over here that there is going to be keratoderma. Keratoderma of the palms and the soles, along with woolly hair and along with ARVCM together, makes it the Naxos syndrome. Is this also a defect in the desmosomes like any other ARVCM? Yes, but particularly which desmosome over here, that is going to be plakoglobin. So another question which is important for NEET and INI aspirants. But of course, the discussion is incomplete without going into clinical aspects. So sir, over to you.
So I think with the exams being postponed, maybe you might have got time to watch Euro 2024. But I just take you back about 4 years ago at Euro 2020, especially guys listening to this who are into sports. I can say a Danish football player, Eriksson, he collapsed on the football pitch in during the match and he had to be given a CPR. Now, what you can understand is if somebody is going to be a football player in Europe in a topmost club and then subsequently playing for his country, they would have invested sufficient money in his genetic testing to ensure that he does not have a hypertrophic cardiomyopathy. So even in Ericsson's case, it did not turn out to be a hypertrophic cardiomyopathy because he was anyway tested for it. I mean, you would have a proper medical team evaluating each one of these football players before they actually go on the pitch, and they would have done these basic screening tests like echocardiography, where the hypertrophic cardiomyopathy would be like kind of in your face. So what did they miss is what we're going to talk about next. And if you read about Ericsson, he is now back in football, obviously not as a player, but he's back, because he loves to do that. He's maybe working as a coach at the moment, and he's back with the ICD, that's the implantable cardioverter defibrillator. And well, his team members ensured that he got CPR as soon as he collapsed. So that's the importance of it. And then subsequently, the medical team took over. And what I want to bring to your notice here is that the question says, and this is line to line from Harrison. I mean, Harrison says that currently, considering the genetic testing facilities that are available, it's unlikely that a player would not be detected for hypertrophic cardiomyopathy. And that's the same thing that I would like to, explain with respect to this particular question. A football player collapses on a pitch, goes into an asystole. His pre-match ECG is shown, and he says which ECG finding was missed by the team doctor, which tells us that there is a problem present here. So when you look at the ECG, if I zoom it into it a bit, you can notice that at the end of the S wave, where the markings are, you can notice a small notch present, and the notch is very, very characteristic for the topic that we're discussing, that is arrhythmogenic right ventricular dysplasia. Before I mention the name here, let's go into exclusion approach. You see, delta wave is what we read with respect to Wolff-Parkinson-White syndrome, and then it has a short PR interval. There would be symptoms of palpitations present. So, I mean, again, somebody with a WPW cannot be expected to be performing at a level of physical stamina that these guys would be required. Then, as far as LV hypertrophy is concerned, we have diagnostic criteria for it. I mean, the important diagnostic criteria for this one would be depth of the S wave in lead number V1, and the height of R wave in lead number V5 should be going to be more than 35. I mean, there are multiple rules, and anyway, ECG is not going to be very, very good for chamber enlargement. But I can say that again, I mean, left hypertrophy, right ventricular hypertrophy, we have some ECG based criteria, and he's giving me a single lead only. In the single lead, what I want to bring to your notice is that I can see a P, I can see a small R, I can see a S, and then I can see this a notch which is present, or something that looks like an alphabet M, and this is going to be an epsilon wave which is encountered in patients of arrhythmogenic right ventricular dysplasia. The problem in this condition is a fibrofatty deposition in the heart, and this fibrofatty deposition is, as ma'am said, abnormal because it's going to cause a creation of a voltage gradient. Most of the time this fibrofatty deposition is found in the right ventricular wall, right, and it's usually present close to the RV epicardium. Now I can put it like this: epicardium, and then I talk about myocardium, they should be having a constant voltage. But if there's a voltage gradient due to fat and fibrosis, that voltage gradient will act like a short circuit and can result in development of an arrhythmia. So what would have happened in Ericsson's case would be, while he was doing this running and chasing the ball, he could have gone into a ventricular fibrillation or a PVT, a pulseless ventricular tachycardia, and then subsequently went into a asystole. Because every time before a person goes into a cardiac arrest, there is a possibility, the terminal event, and that's itself a question. What is a arrhythmia? That can be seen before asystole in majority of cases. It's either a VFib or a PVT, and therefore, I mean, in this particular case that we are talking about, we have to identify an epsilon wave, and that would help us identify and probably save a life on a football field as well. And in the lieu of genetic testing being available nowadays, it's just that we need to expand the testing beyond the scope of only, scanning for only hypertrophic cardiomyopathy. It's all of the cardiomyopathies that need to be evaluated by the team who's going to give a fitness or a medical clearance to these patients who finally go onto the pitch.
So finally, moving on to the last cardiomyopathy that you have to know, which is RCM, or restrictive cardiomyopathy. Of course, this is a diastolic dysfunction, which we will be talking about more with Sir, as Sir will explain us the clinical aspect. But the reason for the diastolic dysfunction is that there is some kind of infiltration that is happening in the heart. One of the more common causes that we have is going to be amyloidosis. And we all know that when we want to detect amyloid, there is a certain stain and a very important characteristic finding. But like I said, any infiltration in the heart, so that could be a myeloidosis, that along with that could be any kind of a storage disease. It could also be, we know heart is a very famous site for metastasis also of a couple of cancers. So anything infiltrating the heart can result in RCM. Since I said one of the most common causes are amyloid, this is a very important question that you get in pathology. If you look at it from the light microscopy point of view, you cannot forget the definition of amyloid, which says that yes, like in pathology, everything is pink and blue, so amyloid comes into the domain of being pink. But the point over here to note is that it is always going to be outside the cells, be it any particular organ of the body. Amyloid is always extracellular. So if you look at these muscle fibers, you will see amyloid is lying outside the muscle fibers. And if you want to confirm it, then I believe all of you already have mugged it up by now, that you will be using the very famous Congo red stain, on which you will get that apple green birefringence, which you can very well see over here. And to visualize any apple green or any birefringence, the microscopy that we always require is the polarizing microscopy. So yes, amyloid being a very important topic overall, and I would want all of you to read it from general path also. But coming back to RCM and the clinical aspect, so over to sir.
So guys, as you are aware that now we are celebrating the 25th anniversary of the Kargil war, and we won it. And the person who orchestrated that from across our borders, General Parvez Musharraf, he actually suffered from amyloidosis. Being a soldier, we obviously have respect for him. But then he died because of restrictive cardiomyopathy. He had features of congestive heart failure, and he expired in Dubai, I think, in 2022. So let's talk about a question with respect to this condition, and that would give you an insight regarding how the disease will evolve. And one of the very characteristic features of this condition would be that because there is fibrosis in the ventricles, so the atria will have to work against a resistance. And because the atria will have to work against a resistance, this particular condition, if they give you a postmortem specimen, then I think ma'am would agree to this, that you would have jumbo-sized atria. Unlike DCM, which all chambers enlarged, hypertrophic cardiomyopathy, interventricular septum hypertrophy, and a free wall enlargement, here it's going to be like left and right ventricle are almost going to be of equal size. They're not going to show a cardiomegaly, but atria are going to be jumbo-sized. So having said that, let's look at this question, which is going to be like a 3 or a 4-liner. He says, patient presents with paroxysmal nocturnal dyspnea. Now, this is a feature very characteristic. You read about Framingham criteria for congestive heart failure. This is one of the major criteria. And then he also says bilateral ankle edema. So that tells me the right side of the heart is also involved. So right when I read the first line, I should understand he's talking about LVF findings and a right ventricular findings. Then he says small sign is noted. That again gives me credibility that, okay, the right side of the heart is involved. In fact, this is a question where there is a biventricular failure, because rails and presence of rails and P&D, that goes in favor of LVF, and small sign and bilateral ankle edema goes in favor of right ventricular failure. Echocardiography shows what I was saying, a biatrial enlargement with increased ventricular wall thickness. Now, this is going to be a statement which can cause error of judgments in the mind of student, because the moment you read the word increased ventricular wall thickness, you start thinking in terms of hypertrophic cardiomyopathy. So I want to tell you that in majority of cases of restrictive cardiomyopathy, the thickness of the RV and the LV wall is going to be normal, but the textbook says / it might be increased as well. So this can be a confounding factor in MCQ that can result in error of judgment, in a sense that when you read this word increased thickness of the ventricular wall, the examiner is trying to misguide you into thinking in terms of hypertrophic cardiomyopathy. And then I think you all love reading this word, starry sky appearance. So we read about starry sky appearance in ultrasound liver for viral hepatitis, starry sky appearance in neurocysticercosis. But today I'm talking about a starry sky appearance which can be seen on an echocardiography in these patients, or can be seen on a cardiac MRI as well. Even if you have not studied echocardiography, or if you not studied regarding cardiac MRI, it really doesn't matter. But even if you look at this cross-sectional image, you can see those jumbo-sized posteriorly situated atria, and then you can see that speckled sort of appearance in the ventricles of the patient. That's the classical starry sky appearance. So the presentation would be easier for you at this point of time, because the topic that we are studying is restrictive cardiomyopathy. But when you look at this question in isolation, they can be errors of judgment as well, because features of heart failure are a standard presentation of all types of cardiomyopathy. So you have to look for keywords. And what's the keyword in this question? Either focus on the word biatrial enlargement or focus on the starry sky appearance, which is a clinical bit that I would like to add to this question.
So on that note, I would also want to ask all of you, where else do you get to see starry sky appearance in pathology, which has not been mentioned over here? So do let us know in the comments below, and that would also help us know how many of you survived through till here.
So the next case that we're going to discuss is a life-threatening event. every time we are exposed to an event where there's a threat to life, there's going to be a surge of catecholamines. Now, catecholamines are responsible for a fight or a flight phenomenon. But today, in this particular MCQ, I'm going to discuss before you catecholamine toxicity that's going to cause so much of damage to the heart that the apex of the heart will dilate. The left ventricle, especially the apex, will dilate. So the condition that we're studying at this moment is also called as apical ballooning syndrome. You see, everything about the heart is all about its shape. If you lose shape, you lose hemodynamics, you lose contractility, you lose the power that the heart can generate to generate an effective cardiac output. And the condition that we're studying at this moment, before I mention the name here, I just would like you to read the first line here. The 60-year-old woman was trapped in an elevator. I mean, in an elevator, in an earthquake. I mean, earthquake is going to be anyway something very, the whole building is shaking, everybody's afraid for their life. And if you're stuck in an elevator, it's even going to be more scary, especially when the light goes off. And luckily, like, she was rescued and then she was sent to the hospital because she was having chest pain. And when we evaluated the ECG, it showed a classical ST elevation in lead 1, AVL, and V1 to V6. So what I make out of this is that this patient could be having an extensive anterior MI due to a thrombus present in the proximal part of the LAD. Therefore, initially I thought it is a case of MI only, and that's what is also given in this question, extensive anterior MI. But then he's mentioning a echocardiographic finding, that is apical bulging and a hypokinesia. So that tells me that this is unlikely to be myocardial infarction. And to be sure, though it's not given in this question, we would still like to do a coronary angiography in this patient. And if we do a coronary angiography, we will see that there is no blockage in any coronary artery by any thrombus. For confirmation or diagnosis of this condition, ideally we should be taking the patient in the cath lab. And there, when we do a coronary angiography, I'm talking about an invasive coronary angiography, which would be done using a transradial or a transfemoral approach, and we'll have the coronary arteries doing perfectly fine. I mean, whether it's going to be proximal LAD, distal LAD, right coronary artery L6, everything is going to be perfect, but it's only the shape of the heart that is distorted and could be picked up on echocardiography as well. In fact, an alternative term for this condition is Takotsubo. Now, what that basically means is, it's a Japanese term. And well, suddenly you'll say, how did Japan come into being? So all I can say is Japanese are fond of seafood, and one of the delicacies that they consume apart from sushi is octopus. So there's a jar which is used to trap an octopus, because I can say that if you focus on this particular area, if an octopus goes inside this, it will have difficulty because the inlet is relatively smaller. So octopus goes inside, it would not be able to come out. So taku tsubo in Japanese means a jar that is used to trap an octopus, and that is why that word has stuck there. And the highlight of this condition is extensive catecholamine release is causing a development of cardiogenic shock. In fact, the peculiarity of this condition is that this is an acute onset cardiomyopathy, because all the conditions that we've discussed prior to this would be having a long-term presentation or a long-standing clinical history present. But in this one, there's no family history of any heart disease. This lady has suffered from acute life-threatening event, which is causing this dysfunction. And the good news is, well, she's going to recover. I need to manage cardiogenic shock in this patient, not using dopamine, dobutamine. Inotropes would not be recommended because already catecholamines are high in the body of this patient. So we will be using is a IABP, that is an intra-aortic balloon pump, that will do a counterpulsation, generate coronary blood flow, and treat the cardiogenic shock of this condition. I repeat the salient feature once again before I mark out the answer. Guys, what we're discussing is an acute onset cardiomyopathy with a good prognosis. Otherwise, in all other cardiomyopathies, there's going to be long-standing history, features of heart failure, and a requirement for a cardiac transplantation. In majority of cases, we'll be deploying an implantable cardioverter defibrillator to prevent sudden death due to tachyarrhythmias. Not here. In majority of these patients, if the diagnosis is made on time and an intra-aortic balloon pump is used initially to manage the cardiac output, well, we'll have a good recovery in this case. So the final diagnosis in this case is option number B, and you can rule out option number A because Brugada syndrome is a sodium channel defect, SCN5A defect, where we get a classical cove pattern of ST segment elevation that I've currently shown before you. That's again a question, especially for INI-CET aspirants. I mean, they always mention that cove pattern. I'm going to draw it once again quickly before you, and what you can see in this particular case is I have just modified whatever I did earlier, where I showed a cove pattern with a T-wave inversion, and now I've shown a wave which is having a saddleback appearance. I mean, that is having a hump, right? Initial elevation, depression, and then an elevation again. So there are actually three varieties of Brugada syndrome, and out of this, I can say at this moment that I want you to be clear about at least two. Difference between 2 and 3, I can say at the moment is, though I'm not going into ECG, is that 2 and 3, the magnitude of ST segment changes would be more. In Brugada type 2, the ST elevation would be more than 1 millimeter. In some books, it's given 2 millimeter. Whereas when it comes to type 3, it would be looking the same, saddleback, and it would be less than 1 millimeter. The query that I get is, sir, you said saddleback for 2 and 3 both. Yes, guys, saddleback is a feature in ECG in both 2 and 3. The difference is with respect to the magnitude of ST segment. So I could not just stop myself from saying that ST segment changes there, because it looks very tempting to say. And then type 1 is going to be having a co-pattern that you need to remember. Well, this is not a presentation of a panic attack. I mean, this is too benign to be something, this is like too aggressive to be compared with something like a panic attack. So you would have ruled it out, option number D, right away. And wrong, I would say, I would not say it wrong. I would say that in a rush to answer, the confounding term ST elevation, lead on AVL and V1 to V6 can result in a person answering this as extensive anti-reval MI as well. But then the echocardiography finding gives justification to our diagnosis in this case as broken heart syndrome.
Thank you so much for joining in and patiently listening to this very important topic. And thank you, sir, for the amazing clinical inputs. And after a very long time, I felt like an educator and a student myself, and I've loved every bit of it.
Thank you, guys, and keep hammering.